I am very happy to introduce our first guest speaker of the morning. She is a professor at the University of Minnesota College of Pharmacy and also a faculty advisor for University of Minnesota's APhA-ASP chapter. She's also a previous chapter president for APhA-ASP when she went to school at the University of Nebraska. So please help me welcome Dr. Ann Philbrick.
Thank you. All right, thank you. Good morning, Minneapolis. Technically Bloomington, but whatever. We won't fuss about it. So this morning, bright and early, 9 a.m., we're going to do an interactive session on myth-busting some vaccines. So does anybody remember Mythbusters, the show on Discovery? All right, we've got some nods here. So does anybody remember, like the thing was that they would take some idea, right, and like bust it, right? Does anybody have like an example of one that they remember? Anybody? Okay. Cell phones on airplanes. I got one over here. Archimedes' death rate. Can you?
Oh, the giant mirror that could like supposedly burn ships from like a mile away.
Oh, nice. That's like a specific nerd one. I love it. I love it. I was just thinking like, they were all, like, the ones I remember were the ones where they would, like, see if something could blow up, right, and then they would blow it up, right? But so that's what we're going to do today. We're going to do, talk about some myths that are common with vaccines, and we're going to go ahead and bust them. This was originally put together by Dr. Skoy at the School of Pharmacy at North Dakota State. So I know we have some North Dakotans in here. You might know Dr. Skoy. But she put this together with APhA. This next slide is just a note that this presentation was funded in part by a grant with the CDC. And so APhA and CDC put together some vaccine resources for the pharmacists. All right, let's talk about how you become a vaccine mythbuster, right? So it takes some background, right? You need to kind of know the guidelines and know what is out there in the literature, what's available for you. So the first thing to talk about is the ACIP. So the ACIP is a group of smart people that make decisions on vaccines. They've been super busy the past 2 years, right, with COVID, but they get together, they review the literature, and then they vote on recommendations for vaccines. That goes to the CDC, and then the CDC puts them together in guidelines and publishes them on their website. Typically, they get published in the Morbidity and Mortality Weekly Report, the MMWR, and then get incorporated into the vaccine schedules there. So we have some information on the slide here about ACIP recommendations and guidelines, and then also a link to the CDC schedules. You don't need to know these websites. I just Google, adult vaccine schedule, and it takes me right to the right page. Typically, the vaccine schedules are updated about annually, and they are just a really, really good reference. They're both grouped into adult vaccines and then childhood vaccines, and then the ones I actually like are the ones that are broken down by like disease states or information that way, because if you have somebody that is immunocompromised, there are some vaccines that we really want to make sure they get, and then there are some vaccines we can't give them because of their immunocompromised status. Just a reminder that both the CDC and the ACIP have been super busy these past 2 years. Of course, things with COVID are rapidly changing, and they've been changing and meeting a lot about those COVID vaccines. But it's also important to remember that there have been other changes that have happened in the past few years, including flu recommendations slightly change annually. We've also had changes in hepatitis B recommendations as well as pneumococcal recommendations. So as pharmacists, as future pharmacists, it's important to keep up on these changes just because we're the vaccine experts, right? All right, available resources. Like I mentioned, the CDC has a lot of information out there. They have the vaccine schedules. They also have some decision trees to kind of help you figure out what's going on, what recommendations you should make. They also have some myth-busting facts of their own. Of course, APhA has a lot of references as well. They have their immunizations Center, as well as the Vaccine Confident website. And throughout this presentation, I'll kind of be showing some of that website and how you could use it as a student pharmacist, as a future pharmacist. And then immunize.org has a lot of information. They have handouts so you can give to your patients. The one thing that I really like about immunize.org is that they have Ask the Expert there. And so this is like you might go through the vaccine schedule on the CDC website and you're like, ooh, but I still don't know what is recommended for this patient because it doesn't quite fit. There's a good chance that Ask the Expert has gone over that, and you can actually submit questions for somebody to ask there. So super great tool for you. This is that Vaccine Confident webpage that I was alluding to earlier. There is just a lot of great information there. On the right side of the screen, you'll see that those are kind of the conversation guides, so common misconceptions about vaccines and how you can handle them. There's also some really great information like recorded presentations about how to handle the different things like social media, stuff that might come across, on Facebook, that kind of thing. And then we want to talk just a little bit about communication strategies. The first is I would recommend being presumptive in your recommendations for patients, and this is most effective when you're pretty confident that the patient's probably going to get a vaccine. But this is being very forthcoming and very confident in your recommendations. So this assumes the patient's going to get vaccinated and might say something like, oh, I see you haven't gotten your flu shot this year. I can go ahead and give it to you today, versus kind of more of a passive situation that would be like, well, do you want your flu shot today? That kind of thing. Again, this works a little bit better if you kind of have a good idea that the patient's not going to throw up a big fight or have any qualms about the vaccine itself. The other two situations you can use when you might have a patient that's questioning, right? And that is the CASE and the EASE strategies. So CASE is the one that I talk to my pharmacy students about, but I do think I'm going to put EASE into the presentation this year. So CASE stands for corroborate, about me, science, and endorse. And so for CASE, which we'll have some exercises later on today about how you can use these, you find a common ground with your patient, right? You acknowledge that it is a valid concern, and it is something that is common to be concerned about. About me is talking about what you have done in order to learn more about the topic at hand. Science is just presenting what the information is out there about that concern, and then E brings it home and you endorse or you give them a recommendation that's like, if it was my child, I would go ahead and give the vaccine, or if it was me, I would get the vaccine. EASE stands for elicit the main concern, acknowledge the main concern, share your commitment, and then educate and endorse. So very, very similar to CASE, but a little bit more in the motivational interviewing realm. So this might be even better when you have maybe a back and forth with your patient. They have a concern, you want to ease that concern, and have a nice little conversation with them. All right. So now we're into the actual fun part, the actual myth busting. So what I'll do is I'll present a myth. We're going to have a poll the audience, which Ron is going to do for me excellently. And then we're going to talk about the myth. We're going to talk about what makes it a myth, what makes it wrong. We'll also talk about some of the scientific evidence to help improve your confidence when it comes to making vaccine recommendations. So it looks like here, this is going to be how you join the poll. I've never done this, so go to this website or take a little picture of that QR code. So the first audience poll is going to be just what are some common myths or misconceptions about vaccines that you have heard, you've experienced maybe while working in a pharmacy, working at maybe Operation Immunization, that kind of thing. go ahead and free text those in, and Ron will report out.
All right, so the common one that I'm typically seeing is vaccines causing autism, making you sick, so like the flu shot getting you sick. I'm gonna get COVID anyway, so why should I get the shot? And then, tracking chips as well. That's a big one recently.
Oh yeah. All right. So the first one I think we're going to talk about here is the myth that the COVID mRNA vaccines can cause infertility. One that's kind of been fairly common. Our next audience poll is going to be on a scale of 1 to 10, with 1 being I do not know how to address this myth, to 10 being I got it. Tell me what your confidence is in addressing this myth.
All right, yeah, so I'm seeing kind of all across the board. Average is about a 5 out of 10, though.
Okay, thank you. Okay, so let's talk about what the science says. First and foremost, it's really not biologically possible, right? The mRNA degrades in the body within 72 hours, and then that fat cell that's in the mRNA vaccine gets degraded within 4 days. So the actual vaccine itself doesn't really stick around in the body. It's basically going to go into the body, tell the cells what to do, and then out of there. The other thing is that we've looked at it. It wasn't really in the prospective approach of the vaccines, but they've looked at all of the people that have gotten the vaccine and looked if there were fertility issues in either any gender. And they've seen that there's been no issue with fertility issues there. Post-vaccine rollout, the V-Safe program has been asking people about those issues. There hasn't been anything that has come up in the V-Safe program. And then we even have a joint statement by some very big groups, so ACOG, ASRM, and then the Society for Maternal Fetal Medicine. And they said, while fertility was not specifically studied in clinical trials of the vaccine, no loss of fertility has been reported among trial participants among the millions who have received the vaccine since they were authorized, and no signs of infertility appeared in animal studies. This is the website of the APhA Vaccine Confident Resources. There was a magazine article in, I think it's called The Student Pharmacist, a couple years ago that talked about how to engage with your peers on vaccine confidence. Also within the APhA playbook, there are 2 sections focused on fertility concerns. And then there's another one directly addressing concerns about vaccinating children and teens. So just some communication strategies. So if I were to use the case method in this situation, I might say something, well, I could understand how that would be important to you. Starting a family seems like it's a very important issue for you. And as your pharmacist, I want you to be able to have your goals as well. I know there's rumors on this topic, and let's address them. As a pharmacist, I make sure I stay updated on accurate information related to vaccination so I can make safe recommendations to my patients. So that's the C and the A. The S might be millions of individuals received an mRNA COVID vaccine around the world. Vaccines have some of the most rigorous monitoring of any medication, and there have not been found to have any association between fertility and vaccination. What I do know is that COVID-19 vaccine can protect you from serious illness. Let's go ahead and get you protected today. So that's just kind of one way you could go about that. All right. So then we're back onto the audience poll. Have I changed your confidence at all?
About half the audience puts themselves at around an 8 out of 10, average around an 8.
The next myth that we're going to talk about is that the vaccines aren't necessary. And so this usually goes 2 different ways. It's the natural immunity is better. I will get a better protection if I were to just get the COVID virus instead of getting the vaccine. Or the other way it can sometimes go is that, like polio isn't even a thing anymore. Why do I need to get that vaccine? All right, so poll the audience question. How do you feel about addressing this one? Again, 1 being not confident at all, 10 being I got this.
Slightly better than the first myth. We're at an average around 6.5. About a fourth of the audience gives them about a 7.
Excellent. The slide on the left side of the screen, or the image on the left side of the screen, looks at diseases in the United States between the 1900s compared to 2019. And so this is essentially what the advent of vaccines has done to us. I just want to point a couple things out. Diphtheria, pretty much non-existent. 2 cases in 2019. Measles, in the 1900s we saw, hundreds of thousands of cases. Now it hovers around maybe 1,200. Certainly there are pockets that appear if you have a pocket of patients that happen to not get vaccinated, or a community of patients that happen to not get vaccinated. Polio is essentially eradicated, although I think we're seeing maybe a little bit of a pocket happening in New York right now. On the left side of the screen, again, we have kind of what cases are now in the United States. I would say that pertussis continues to be kind of a troublesome issue for us, and I could go into that a little bit later or longer, but I won't. And then, of course, we do see kind of pockets of different things that do appear, but we've got things like tetanus and diphtheria, smallpox, and rubella that essentially are non-existent because of vaccines. All right, so what does the science say? I think the previous slide shows us that vaccination has decreased the rates of serious disease and death associated with those diseases. Certainly, the other thing we've seen is that in areas where vaccination rates are lower, we do see outbreaks of vaccine-preventable diseases, and that's because we're not hitting that vaccination threshold. If you look on the left side of the screen, no, the right side of the screen, sorry, we have the vaccine-preventable disease and then the vaccination rate that's needed for herd immunity, that little chart there. And essentially, if your vaccination rate falls below that threshold for herd immunity, that's when you might start getting breakouts of these cases, because we're no longer relying on herd immunity. We can't have that as a backup. Some of these are pretty high, right? So measles, for instance, you need to have 92 to 94% of your group, your area, your herd vaccinated in order to protect against that. So, if we had, there's probably about 100 people here. If we had 8 people that weren't vaccinated, we would be at risk here. The other thing that's a little bit scary to think about is that every disease we vaccinate against is just an airplane ride away. I think COVID taught us that, right? Within a matter of months, COVID was worldwide from when it was first identified. And I've already talked about herd immunity. So this is our APhA vaccine confident resources. This is just basic information on strategies to engage with communities who may be disproportionately affected by COVID-19. All right, so now we have a table activity, and you should have some worksheets at your table. And this is to work with maybe the people at your table, the person sitting next to you, on how you might use the case approach in order to address this concern about vaccines not being necessary. Does somebody want to share the case that they came up with?
I said, it is important to protect your health and others around you. I stay up to date on best ways to protect your health through CDC guidelines, and vaccinations are consistently important. If not enough people get vaccinated, then vaccines aren't helpful to those that don't get them. You should get your vaccination today.
Wonderful. Excellent. Thank you. Okay, and now we'll do our post audience poll. See how your confidence changed.
All right, getting those last votes in. About half of the audience is putting themselves at a 9 out of 10. We're at an average of like 8.6.
All right, our next myth is pretty common. Ingredients found in the vaccines are harmful. So, what's your confidence on addressing this one?
So the past two MRMs that I've been to, this question has typically been the lowest pre-score, but this one's at around a 5.5. So.
All right. So what does the science say about this? We just pulled out a couple of the more common ones that people tend to have an issue with. Thimerosal, we know that thimerosal is a form of mercury that is often found in fish and can be harmful if ingested highly. The truth of the matter is that it was removed from all childhood vaccines I think in the early 2000s, and currently it's only found in multi-dose vials of influenza. It's just not in vaccines currently. I do think that there's some information out there that says that thimerosal is linked to autism. I know that autism is a devastating disease sometimes, but we continue to have cases of autism despite removing thimerosal from the vaccine several years ago. Formaldehyde is often used in vaccines to help inactivate that particle for an inactivated vaccine. The truth of the matter is that there's just very, very little formaldehyde in the actual vaccine. There's actually, this is really kind of crazy, but there's 12,000 micrograms of formaldehyde in one pear, which is maybe why I don't like pears. No, I just don't like the texture. And vaccines can have up to 100 micrograms of formaldehyde per dose, and that's like about 0.83% of a pear. So again, very, very small doses. The same with aluminum. By 6 months of age, formula-fed babies ingest about 40 milligrams of aluminum, and by that same age, they only receive about 4 milligrams of aluminum via vaccination. So very, very small components there. So this is the APhA Confident website. This particular page looks at the vaccine development process and approval process, and just making sure that the contents of the vaccines are safe for injection. So then let's talk about how your confidence has changed.
About half the audience puts themselves at around an 8 out of 10, average around an 8.
Thank you. All right, and now it is time for our last myth. And this is, it's better to follow an alternative vaccination schedule. And kind of the idea behind this is too much too soon, right? Too many too soon, that kind of thing. So how do we feel about this, addressing this myth?
Lower average on this one, we're about 4.5 roughly.
All right, thank you. So let's talk about the science. I think one of the things that trips people up right now is that we give more vaccines to kids now than we did, in 1960. I was born in 1982. You can do the math. I'm 40. I got like 6 routine vaccines, right? And there's a lot more now that we give kids. So it just seems like, gosh, that's a lot of pokes to be giving a kid. The truth of the matter is that vaccines have gotten better over time, right? And so in 1960, when there were 6 routine vaccines that we gave to kids, there were about 3,200 antigens, or the active particle in the vaccine itself. In 2000, when the number of routine vaccines we gave to kids was 11, that was only 126 antigens. So even though we're giving more vaccines and we're protecting against more diseases, we're actually using less antigen because we've gotten better at that science. The other thing is that this idea that getting the disease itself might be better protection. If a person gets infected with a vaccine-preventable disease, they're actually exposing themselves to a higher amount of antigen than they would with that actual vaccine. We also have other issues with that, right? You could actually get sick. It's the idea of getting vaccinated against COVID versus actually getting COVID, right? The vaccines themselves on infants are really kind of low on their immune system, right? It's not too taxing on their immune system. It really only uses about 0.1% of their immune system. Whereas, again, if they were to get sick, it would really kind of put their immune system at work in order to fight off that disease. The other issue with spreading out the schedules is that it increases the time that a person is put at risk. Some of our vaccines already are not completed until the age of 5 or 6. If you're spreading those out, then you're increasing the time that the patient is at risk for a vaccine-preventable disease. It's also pretty easy to get behind schedule that way. And so, you might see patients that are, 7 or 10 that have never gotten these routine vaccines. It also can it causes more medical appointments, which kind of leads to maybe an increased expense in that idea that you might get behind a little bit. Just a quick little plug here. The CDC does post catch-up schedules, so if you're working in a pharmacy, if maybe you're doing an operation immunization program where you're talking to people about what vaccines are necessary, that is a really great tool to use to figure out what is recommended for those patients. It's also a really good role for a student pharmacist or a pharmacist to play, is to help get people caught up. Particularly right now with the PrEP Act in effect, we as pharmacists can actually administer some of those childhood vaccines, and really a lot of states have come on board in what they allow pharmacies to vaccinate as well. This is the APhA Vaccine Confident Resources. This particular one is the guide to the COVID vaccination schedules and making sure that patients keep up on those. A really great resource because, gosh, it is confusing right now with the boosters and the different vaccines that are out there. So really great resource from APhA. Now we have our second table activity. So talk about this situation and use the EASE method, which again is elicit the main concern, acknowledge the main concern, share your commitment, and then educate or endorse. Just to give an example of using the EASE method. Anybody?
So we would just elicit the main concern, which is that, yep, this is a lot of vaccines. Like, I understand, you don't want to be giving a lot of needles to your kid. But so acknowledging that while it may seem like there's a lot of medications you're giving them, this is really going to benefit them longer term and prevent them from developing a disease where they could end up in the hospital and get something else. And then commitment in terms of we really want the best for your child and you. We're not trying to just push this to push it. We want the best health for your child. And then educate and endorse that we are educated pharmacists. We keep up to date on everything, especially with all of the new changes to the COVID scheduling. We're here to give you the best evidence-based medicine that we can.
Thank you. Thank you.
I actually have a question.
Oh, excellent.
So especially with the pandemic kind of pushing a lot of people, a lot of other vaccines, I think, to a little bit to the wayside with all the implementation of the COVID vaccines. There have been a lot of people that have missed, say, like their shingles doses, or got one dose of shingles and missed another one, or the pneumococcal vaccines, especially as one gentleman was talking about some of those older patients. So, what would you say is good advice for us to kind of address that for people that have missed doses, or have missed some vaccines such as those?
Yeah, I mean, I would start with the proactive approach that we talked about earlier on. That was the you review at the time of a fill or the time of a visit with the patient and say like, oh, I see you got one shingle shot here. It's actually a 2-dose series. Can we go ahead and get that today? Or I can give that to you today. And just kind of follow up on the importance of making sure that you continue the series, particularly with shingles. Shingles kind of hurts, right? And so particularly with shingles, I make sure that the patient knows up front that this one's going to hurt, but it's important to get 2 so that they're kind of prepped for something's going to hurt bad, and then maybe it won't hurt as bad as they thought it was going to. And then they're prepped that, yes, I do need to get a second one. Great role for pharmacists to play, though, particularly your adults that may not be going into the physician's office on a regular basis, but maybe coming into the pharmacy a little bit more often.
I know the schedule for Shingrix for that second dose is anywhere from like 2 to 6 months after the first dose. If someone's like, say, way beyond that, and maybe got it before COVID, and then their first dose, and then it's like 2 years later, and they haven't gotten that second dose.
As soon as you can get it.
As
Don't
soon as
have
you
to
can get it.
restart.
Okay, gotcha.
So as soon as you can get it. Okay. Our audience poll. So vaccine confidence on an alternative schedule.
About 80% of participants put themselves at an 8 or higher.
Excellent, excellent. Good work. All right, so we're just going to wrap things up here. Final audience poll is, what's your biggest takeaway from this session? What's the one thing that you learned that you're going to put into practice?
Pears. Pears have formaldehyde. That was a big one, and it's pears in all caps and exclamation points. That caught my eye. Communication is key. Meeting the patient where they are at. Acknowledging the fears is really important in starting a comfortable conversation. I like that one. Pears. There's a lot of pears.
Okay. We took home that pears have formaldehyde.
It's important to make sure that your patients trust you. An effective way to talk to others who have different viewpoints, of course. And then people saying that they've really improved and found confidence in addressing immunization questions.
Excellent. Thank you. So just to wrap things up here, know the guidelines pretty well. I feel like I know them fairly well because I do teach immunizations, but they are there for you to use as a reference. Use scientific evidence, and then practice communication strategies using the CASE and the EASE method. Any other questions?
How do you recommend addressing when a patient asks why they need to receive another COVID booster if they've already gotten one?
Just sit down and say, we do recommend that the patients get this bivalent booster now that is available. For me, it just makes sense. Like, I know it's safe. I know that it's a fine vaccine to get. In my mind, I got it, right? And I would recommend it for my patients because it's better than the alternative. It's just one more thing that you can do to protect yourself against COVID. For me particularly, I look at like how long it's been since the person got maybe their previous booster and talk about, we get flu shots every year. Maybe COVID is going to be the new flu shot where we just have to get something every year, that kind of thing. Anybody else have any great strategies for COVID? Otherwise, I'm checking my time here. Oh, we're 10:01. We're perfect. So thank you, and I'll be back tomorrow to talk about HPV.